Welcome back, everybody. Have had a very good lecture series so far. We now proceed with the last lecture of session 3, which is sarcoma, and we will proceed after this final lecture with Dr. Piero Fossati to session 4 on prostate. So, Dr. Fossati, thank you so much for being with us again. And also for the help that you have given us to put the lineup of our lectures together. Dr. Fossati, I give you the floor.
Thanks a lot, Nicholas. So we will just present one practical case of a very common indication for carbon ion, which is sacral chordoma. And there are several ongoing trials, and one of them I'm more involved, and you will hear about the Sacral trial about sacral chordoma on Friday, but today we just focus on a single case. So I guess you see my screen because there's no feedback that it's not the case, so we will go.
Yes, it's okay.
Okay, so this was a young patient, 35 years old, very healthy, that started to have quite worrisome, or rather worrisome symptoms: urinary retention, fecal retention, hypoesthesia, sorry for the typo, in the perineal area, and mild sacral pain, and had no significant comorbidities. So this is, of course, the first big problems with this sacral sarcoma, sacral sarcoma, or sarcoma of the both bone and soft tissue in the let's say, pelvis and lumbar spine are extremely rare. If you just look at sacral chordoma, well, it is something like 0.6 per million inhabitants. So definition of rare tumor is less than 6 per 100,000. So here we are almost 100 times more rare than rare. And this means that you can be a very good doctor without having ever seen a sacral chordoma, without possibly not even remembering what a sacral chordoma is. So there is quite often, or rather often, a diagnostic delay. So the patient presenting with just lumbar pain, it is most of the time a simple benign pain. It is one of the most common reasons why you go to the general practitioner. So in most of our patients, the big headache is how much time is lost, when you should stop with NSAID and massage and do some investigation. This was not the case in this patient. The symptoms were rather worrisome from the very beginning, and so she was relatively early on investigated with an MRI, and in an MRI you see here it is basically normal, and yet you start to see something that should not be there. So the diagnostic MRI that we get for this one is not always exactly what we would like. Quite often, as this was the case, we get just a sagittal plane with the T2, because T2 weighted images are normally not very high priority when you do this, and sagittal is enough, and then maybe you get only contrast enhanced axial. Well, there is a little bit of a difference in the way that a purely diagnostic MRI is done, and that the MRI is done if it has to be used in a radiation setting. Anyway, here you see the tumor that was infiltrating the bone, extending a bit in the presacral space, and you can see that it was inside the nerve roots. So it is, if you want, quite surprising that the patient had not severe pain, because it seems that the bone is really filling, that the tumor is really filling the neuroforamina. But okay, the other thing which is not entirely reassuring is that this tumor seems to be really in touch with the rectum. At least in these slice, it's really touching. Then you go down. Of course, this one is the uterus, but we don't care so much. And you see that the tumor is infiltrating the piriform muscle on the left side, in this case with the patient in prone position. Left in the skin is left in the patient. And you can see also in the right side piriform muscle, there is tumor infiltration. Significant surface of contact with the rectum and bowel, also with the gynecological organs. And not a major infiltration in the glute. Here, again, we see it touches the rectum. We don't like this very much. Boom, boom. Okay, so the symptoms were worrisome. Patient undergoes imaging. They find a space-occupying lesion. And again, this chordoma, when you know that you are looking for something that might be a chordoma, and if you find a mass like that in the sacrum, you should think it could be a chordoma. Well, this chordoma, you really see them very well in T2. They are gelatinous masses with a lot of myxoid component and water. So they are very bright in T2, and they don't have very big vascularization. So T1 post-contrast is not the ideal. But in T2, normally, from a purely diagnostic MRI done in a patient that has some back pain, you just get the axial, which is not always the best for us. So this is described as a purely S3 tumor. So you know that it's a completely different story in the sacrum if you have a tumor originating from the first sacral vertebra or the second sacral vertebra, or if it is third, fourth, fifth, or coccyx. And in theory, surgery for a high sacral tumor, so S1, S2, is extremely mutilating and can have significant risk of urinary incontinence, fecal incontinence, and chronic pain that could really limit the quality of life of the patient. But surgery for a lesion from S3 and below should be easier to perform with less sequelae. So if you read chordoma, which is what was confirmed at biopsy, and a tumor originating from S3 plus young patient, you might think that surgery could be the first option. Now, this sacral chordoma is, of course, a tumor in which you aim for definitive cure and long-term survival, and you hope to preserve quality of life. In this case, the real trick, and it's not only this case, it is quite representative of what happens, is not really at what level did the tumor originate in the sacrum, and then you can say it is S3. But the right question to ask is which nerve roots are in touch with the tumor. And if you contour the nerve roots, then you realize that the S1 nerve roots and the S2 nerve roots are really passing very close to the tumor. So despite the fact that the tumor originates from the third sacral vertebra, if you want to carefully plan surgery, you have to consider that the risk of damaging the most important S1 and S2 nerve roots that will eventually lead to the severe problems is absolutely not zero, because yes, the tumor might originate a bit lower, but then when the nerve roots also go lower and anteriorly, that they are lying very close to the tumor. So the surgeon in this case made his very careful evaluation and told to the patient, yes, I can resect this tumor, but you have significant risk of toxicity, which can be incontinence and can be chronic pain. And normally in a case like that, the surgeon is not telling to the patient that she might end up in a wheelchair, which of course is not foreseen and is a very rare complication of a sacrectomy at the level of S3, but it's not unheard of, let's say. So which therapy would you consider for a tumor like this? You have basically two therapies that have been tried with radical intent, with curative intent. One is radical surgery, trying to achieve an R0 resection, and the other one is very high dose particle therapy. As far as I am aware of, with a very recent update, there is really no one pushing for radical treatment with photons for sacral chordoma. It might be because they are so rare that no one is really interested, or it might be because the historical data about particle therapy are well established, or it might be because people with photons really think that it's not a good idea. We don't know which of the three. So the main decision you have is surgery, which was the gold standard and the only option until, let's say, 10 years ago, or particle therapy according to the published Japanese data. And then after that, other centers followed in this sacral chordoma. And if you go for surgery, most of the time, you will still need postoperative radiation, because it's very, very difficult to have a complete R0, complete clean margins, because still the tumor is passing close to important nerve roots, so you want to try and protect them. There is indeed another option, which is not really well established, but is performed in a quite important and famous institution. So this is the colleagues of the spine surgery department in Budapest that have very, very long and high quality experience about oncology in the spine and in the sacrum. And so Professor Varga established the debulking surgery for sacral chordoma, followed by high dose radiation. So this is something you would think of when the tumor is very big and the bulk of the tumor is the main symptom. So the patient cannot sit and cannot lay down because there is a very large protruding mass. In this case, the growth was internal, so this was not even to be considered a good candidate for this debulking plus. So here the option was radiation with high dose particle, carbon ion, or surgery. In this case, the patient was not very well. I mean, she was rather unhappy about surgery and the toxicity that surgery could have caused in her case. So it was the case for several years in the past, in which we said surgery is still the gold standard, and you should do surgery only in patients that are inoperable or in patients that refuse surgery. And this has gradually changed. Has changed because of mostly the first NIRS, then QST, then J-Cross experience in Japan. That was the first country where they started to say, no, even if the patient is operable, even if the surgeon says, I can take it out, and toxicity is acceptable, we can do a better job because our toxicity is more acceptable than surgical toxicity. So at the moment in Europe, we have an ongoing trial. You will hear more of that on Friday, and we are trying to treat this patient inside the trial. So even if the patient is operable, and even if the patient says, well, it's not like I completely refuse, we offer the option together with the surgeon with whom we cooperate to go for surgery or for particle. So in this case, it was not a matter of asking to the patient, only if you refuse surgery, we treat you with particles, which is the case for other sarcomas. It was not a matter of telling to the patient, we are better than surgery. We offered enrollment in the Sacral trial, and she was treated inside the Sacral trial. What are we doing in this Sacral trial? It is a high-dose carbon ion radiotherapy according to the Japanese experience, but taking into account the differences between the different RBE system. So in practice, we are creating a larger volume, the PTV1, that takes into account tumor plus areas at risk of microscopic involvement, as always is the case in radiation oncology. And this one we treat with 9 fraction of 4.6 gray RBE at 4 fraction per week. And then the PTV2, which is the tumor plus a margin, we treat with 7 fraction 4.6 times 7. Total dose is 73.6. A lot of this is very similar to the Japanese experience, and some of it is different. So 16 fraction over 4 weeks at 4 per week is exactly identical to what was done in the historical trials by Dr. Imai and what is done today in Japan. But 4.6 is a different number after several dose escalation and even dose de-escalation and checking the best balance between toxicity and efficacy. Now in Japan, all the centers treating with carbon ion, with the possible exception of Yogo that tests carbon and proton and does something different, but all the other carbon ion centers in Japan are treating with 4.2 times 16. So 4.2 times 16 with the Japanese RBE system is a total of 67.2. Instead of 67.2 at 4.2, we treat 4.6 times 16 to a total of 73.6. This is based on the conversion that we were discussing yesterday. So this is, we believe, the best way to reproduce with a different RBE system what was done and what was published and what we know is effective in this kind of tumor. And then, of course, we have the dose constraints, and also for the dose constraints, we have to take care of both systems. So most important is the rectum. Rectum, as you have seen, is very close to this tumor. And honestly, in the past experience in Japan, and then in Italy, and now here in Austria, we have seen that rectal toxicity is very limited in these patients. So it is a pity to compromise probability of local control and ultimately possibly cure to overspare the rectum. So what we have as a constraint in our European LEM RV system is 1 cc of rectum should stay below 66. We have other data points, but they are almost always automatically respected. The critical one is this: 1 cubic centimeter staying at 66, and 73 and 66. Well, it's not such a huge difference. It's normally relatively easy to respect that. In our own LEM RB system, we are also trying to keep cauda equina, which is just the very caudal part of the cauda equina, and in this case was not really an issue, to less than 70. And we are trying to spare as much as possible the risk of neuropathy, because indeed we are trying to have this treatment as an alternative to a surgery which is potentially very toxic, but it's not like this treatment has no side effects, not at all. We have our fair share, especially of sacral insufficiency fracture and neuropathy. So this is an attempt to keep the nerve roots that can be spared to below a very risky dose. In this case, young woman, we also wanted to preserve hormonal function and fertility, and as you know, ovaries are very unfriendly organs for radiation. So despite our attempt of giving 73 gray to the sacrum, we wanted to keep at least 1 ovary at less than 2 gray. And this is something which is possibly a difference between particle and modern day radiotherapy, that what is a bit far away, you can keep to really sparing those, even though we are talking of, let's say, fertility in a young female. Now, in this case, we said, yes, we can treat, but honestly, the big headache is that the tumor that here is white is touching 2 organs, uterus and rectum. The patient said that for her personal condition, pregnancy was not really an issue. Anyway, she was young, and patient can change their mind. So we said, yes, okay, understood, but we try to do our best even to spare the uterus, but it's not our top priority. Top priority is sparing the rectum, and it was really in touch. So we did what we are routinely doing in this patient. We asked our colleagues from the surgery department to insert a spacer. Spacers are used in carbon ion radiotherapy more than in other kinds of radiotherapy, just because we have this very effective beam that does horrible damage, which is horrible, but is good if you do it to the tumor, but is horrible if you do it to the organs at risk. So we are very good at sparing what is 5-6 millimeters outside of the tumor, but what is in touch with the tumor might have some significant toxicity. So spacer, surgical spacer insertion is something that we like quite a lot. It is done with Gore-Tex spacer in Japan. It was done with silicone in Italy, and in Austria we have established this workflow in which we use biological spacers. So it is a tissue derived from the skin of sheep from New Zealand. So it is New Zealand sheep skin that you fold several times and you put there. So we will come back a little bit on the spacer. I would like to show you what are we treating. And this is the other thing which is slightly different from the Japanese experience. In Japan, they were mostly focusing on the tumor and adding not very large margins. But when we started doing it in Europe, there were several surgeons saying, well, you know what, I would not really agree to have this prospective trials in which we decide surgery or radiation if you don't cover adequately the parts that I am afraid will be at risk of recurrence. And so we are worried mostly of 3 things: the piriform muscles, the gluteus muscles, and the bone itself. So if the tumor is infiltrating a muscle, we believe there is a significant risk that it could give skip metastasis by infiltrating along the muscle. So we consider what is edematous in the muscle, as you see in T2 MRI, and we include that. And we also consider that we have to be a little bit more generous in the bones. So here you see what we are contouring. This is the low dose CTV. So even though the tumor was originating from S3, we included in the low dose basically the entire sacrum. And then here you have the high dose CTV, and here you have the tumor itself. So you see, because the tumor in the presacral space was extending on the right side, also the high dose CTV extends on the right side. And because the tumor was not really infiltrating the glute, we don't have such big margins on the glute. If this here in MRI, if there was some nodules, some growth inside, then we would have had definitely a bigger margin for the CTV2 on the glutes. And instead, we include entirely the piriform muscles because of this behavior in here. You see the tumor is infiltrating the muscle. Then we put, we routinely put the CTV1 to the bone, to the iliac bone. Those are the main, these volumes are slightly bigger than the Japanese volume. The other thing that you might find, and it's not really common, you know, there are guidelines to contour the sacral plexus. Well, we believe that you don't really need guidelines. We believe that if you look hard enough, you can really identify the single nerve roots, and we routinely try to contour the sacral nerve roots until they eventually merge into the ischiatic nerve. So going back to our volumes, the GTV we define with MRI, the CTV2 has some margins in the muscles, and the CTV1 is really including the piriform entirely, and in the bone some generous margins. And the biggest topic of debate is always how much glute. In this case, we convinced ourselves that there was no macroscopic infiltration of the glute, so we didn't need gigantic margins there. So this is the way in which we contour this sacral chordoma patient, and is quite well standardized in the sacral trial. And here you see some sagittal and coronal view, and it's really touching the. Now, in this case, we said we really need the spacer. We asked to the surgeon to insert the spacer, and unfortunately, you see here in green, the things didn't really work out as we wanted. The spacer was inserted, but was mostly on the wrong side. So if you look in sagittal, you see how nicely you can put 5 millimeters of stuff to separate your tumor from what is in front. But in this case, unfortunately, the tumor was separated from the uterus and not from the rectum, which is the most critical organs at risk. So here you see in violet, it's what they call sigmoid and then rectum, but I mean, we wanted to have this green thing on the other side, and it didn't happen. And also interesting to see is one ovary is really pushed to our volume, so basically impossible to spare, but the other ovaries is behind the rectum from the point of view of the tumor. So this is the one that we wanted to keep at less than 2 gray. We created also an ITV of the ovary over several images. Now, normally the spacer works much better. This is an example that shows you have to establish a workflow with your surgeon, and there is also a learning curve, because after a couple of procedures, now we are basically super happy with our spacer. This is another patient. Here you see the tumor, here you see the spacer. In the MRI, you can really see the multiple folds of this sheep skin that are put in, and you see how nicely we can separate the rectum normally. But just be aware, it doesn't always turn out as it should. So this is our standard, what we like, but the case I'm presenting today is a case in which the spacer was in the wrong place. We are treating this sequentially, so first 9 fraction of PTV1 and then 7 fraction of PTV2, and we are treating all in all with 4 beams, but normally we try to reduce the number of beams that is delivered every day. So we have this idea of using every day multiple beams, but not all the beams. So we create separate beam sets. For this sacral chordoma, we normally try to have 3 beams every day. So in this case, it was quite simple. It was the first phase with 1 to 3 beams, and the beams were straight in the coronal plane, and then the boost was with 1 of the beams tilted. So all in all, we had 4 directions coming. And this is another interesting thing. You know, there is the difference between optimizing with multi-field optimization or single field optimization. And in protons, you really have the choice. And if you do single field optimization, then each beam covers entirely the target. And this is potentially more robust because if the patient moves between one beam and the other, then you have no matching junctions. Everything is uniform. Instead, if you do multi-field optimization, then not every beam is covering all the target. So you can have more conformality, more sparing of things that are inside because you don't pass through an organ if you can reach that part of the target from another direction. But to do multi-field optimization with protons, you have to match junctions of uneven physical dose distribution. So it is potentially less robust against motion between one beam and the other. And our point of view is that with carbon, you don't really have the choice because the RB is non-linear with physical dose, and it depends on the spectra of the mixed field of particles. So you cannot optimize one beam to be uniform and then another beam to be uniform, and then you deliver them together sequentially, and the result is no longer uniform because the RB has changed in a non-linear way. So it's not the sum of the two RB weighted dose. So in our approach in MedAustron, and I say it is also the same that they are doing in many other centers, we always optimize all the beams together to avoid this error of adding up a single field optimized beams that they will no longer be homogeneous in terms of RB weighted dose. However, it is also to be acknowledged that it is not a big error we introduce. So there are other centers, for example, Heidelberg, that when they treat with opposed beams, they say, okay, this is a bit theoretical, you can still do it. Yes, it will result in some inhomogeneity, but who cares? And in the end, there is more robustness. So what we are now hoping for is in the next generation of TPS to have the possibility of a SFO-like MFO optimization with carbon. So it means you still optimize all the beams together, so you properly and correctly account for the nonlinearity of the RBE, but you tell to the optimizer, try to avoid massive gradients, make the gradients as small as possible so that it is as robust as possible to intrafraction movement. Here you see the dose distribution in one slide. And you see also quite interestingly how the 2 gray in white is really barely touching the ovaries. So this you can achieve, but it's not for free. To achieve that, you cannot use the vertical beam in the part that overshoots in the ovary because the fragmentation tail would have. So you see how you have the fragmentation tail where there is no ovary, cranially and medially, but it means that all these spots coming from the vertical beam are not used because they would create too much dose to the ovary. So these are isodoses of the high dose per fraction, and you see how you can nicely cover the tumor and how the 66 gray constraint for sigmoid and rectum with 73.6 for the target does not really lead to a significant underdose, even though the spacer is in the wrong place. Anyway, a little bit of underdose is there. We have very sharp gradient. We are happy of that, but we are even happier when we have the spacer and we don't have to rely on the gradient because then you have to do a lot of control imaging to make sure that there are not small changes that could affect your plan. Here you see dose distribution, and you see how we are sparing the nerve roots that are outside of the high dose target volume. And you can see how the nerve roots reach maximum dose, but we try to spare them as much as possible. So here in yellow, you have the nerve roots, and you see that we try to reduce the length of stretch, which is getting full dose. You can see quite nice coverage of the high dose volumes, and you can see how sigmoid and rectum and bowel loops are kept to very low dose, and now leftover is kept to very, very low dose. So again, our constraints are 66 for the cauda. In this case, we said cauda is far away, so we can be more conservative and not put the 70, but put more. And anyway, it got 21, so just to show you. Colon is getting nothing. Leftover, we wanted to have 1.5 average dose. Well, in reality, we wanted to have 2, but we were quite aware it would have been very challenging. So we asked for more, and then we got 1.7, which was less than 2. So sometimes you have to cheat with the clinical goals to really get what you want, as this was the case. And here you see that 66 for the rectum was not really so hard to achieve, and even for sigmoid, it was not so hard to achieve. But this is the final plan that we had adapted on multiple control CTs. So if you go for 66, you take all the constraints on the first CT, then possibly you will have bad surprises. So there is a practical part to it in which you really have to learn how to do this according to your system and your experience. Now, again, 73.6 in LEM, 67.2 in MKM, and this means that we wanted the tumor to be covered in both systems. So you see here, the red ISO dose is the LEM prescription dose, actually the 98% of the LEM prescription dose, and was very nicely covering the tumor. But you don't automatically get also coverage in the other system. But in this case, the coverage in the other system was quite nice. Of course, you have to look at different numbers, 73, 67. So here you have 72, and here you have to take this, which is the 98 and the 95%, and is still acceptable. So this is what I was telling you yesterday. We are now looking at both systems. The nominal one we use to optimize, and the other one, and we try to have plans that are created in such a way, taking into account beam arrangement, the number of beams, etc., that they look very good in the nominal system, but they still look acceptable also in the other system. So here you see the very nice almost square DVH in LEM, but you also see that we don't want too much underdose in MKM. So we have MKM that would be 67 in Japan. Well, part of the tumor gets more, but we make sure this part that gets more is not the nerve roots, and parts gets less, and we try to make sure that less is not too much less. So this is indeed a new approach that since 2 or 3 years we are routinely doing for all patients, looking at both systems and not only one system. And for the rectum, we have the 66 gray RBE, but as I was mentioning yesterday, we are no longer happy with just looking at one system for the dose constraints. So it must be fulfilled in LEM, but also the 60 gray MKM must be fulfilled. So we have the two systems with different numbers, and we look at both of them, and they must both be fulfilled. And for the nerve roots, we always know that with these 16 fractions, the MKM is lower, and we have this 73, 71, which is the level we look at LEM, but we also try to avoid to have, and this is particularly important because when you do this recomputation with the other system, you always have cold parts and hot parts. So we don't want the hot parts, which are the parts with a lot of ILET, because MKM gives a bigger premium to high ILET when it computes the RBE. We don't want them to end up in the nerve root. So what we try to do is, we know there are hot spots in MKM, very small, but they must not be in the nerve roots. So here again, you see that the MKM recomputation for nerve roots, especially for the nerve roots inside the target, where we say it would be risky to spare, well, we don't want hotspot in the nerve roots, especially we don't want hotspots in MKM, which means more high LET in the nerve roots. And then the ovaries, because of the low dose and the intrinsic difference in RB weighted dose, when you recompute a low dose in LEM, then the MKM will be much lower. When you recompute a high dose in LEM, the MKM a bit lower, and when you recompute a hotspot in LEM, it could even be hotter in LEM. So the left ovary that was paired to average 1.7 in LEM was paired to average less than 0.5 in MKM. And the right ovary, you see, is completely inside the target, and these are those that cannot be spared at all. So with this plan, what were we telling to the patient? We were telling her rectal toxicity, we believe, will not happen. Hormonal function, we believe it will be spared. Fertility, the uterus has been irradiated, so it's very hard to see what happens to the fibrosis or elasticity of the uterine wall. But she said, well, anyway, I don't want any pregnancy. I'm not planning any pregnancy. I will never have any pregnancy. We agreed if you change your mind before trying to get a pregnancy, we have to discuss and discuss also with the gynecologist, not the possibility of achieving a pregnancy, but the risk of uterine rupture because of the irradiation in the posterior wall. But what we said could be a very likely occurrence was neuropathy or bone fracture. So as said, this is a very steep gradient. If you do these treatments, you have to check that things are still true. And so we routinely do control CT and we recompute, and you can see how the small bowel on one day was a bit hot, but then we repeated and it was not. So you cannot really trust the initial plan for 4 weeks, especially when you go with high gradients close to radiosensitive organs. If you have a good spacer, then you do less control CT. And if the spacer ends up in the wrong place, then you need to do more control CTs. And the other thing I was telling you, nerve roots, they get to full dose, but we plan in such a way that if there is a hot spot and you can really see where is the risk of overshoot, well, the hot spot will not be there. So there was one bad day for hot spots in the target, but that was not in the nerve roots. So again, these are small, but not so small things. It's the practical part that you don't really learn in textbooks and make quite some difference between a good plan and a plan that is maybe looking nice, but is not as good as that. And ovary also we planned, there's some motility of the ovary, needless to say, but it was always paired as intended. So at 9 months, we recontoured and there was some shrinkage. The red contour is supposed to be tumor at treatment and the green at 9 months. And at 12 months, there was significant shrinkage. This is the pink recontouring of the tumors, so it had reduced almost to 1/3. But there was also some toxicity. You can see here in the sacrum, the insufficiency factor. But at that time, that was asymptomatic, and the patient had a perfectly fine life. And that was at 21 months. And then this is our initial experience of how fast or how slow will sacral chordoma shrink after carbon ion. So it doesn't disappear. RECIST criteria are really not interesting to evaluate response. Sometimes you have a swelling in the first 3 or 9 months, and some tumors shrink very slowly and some tumors shrink faster. And we are trying to understand why is that so. But you really have to follow this patient for several years and evaluate the response over years. In her case, because of this ovary sparing, we were forced not to put beams, spots from the vertical here. And because we were not putting them here, we were getting a very strange mix of spots. And this resulted in more high LET in the target. So there will be talk about high LET painting, but this patient so far is the one that we have treated with the highest high LET in the target, and is also the one shrinking highest. I'm not saying anything, it's just an anecdote, but we are investigating this topic. You see, because of the sparing of the beams that should not potentially overshoot in the ovaries, there is a very inhomogeneous spot space. After 26 months, the asymptomatic sacral fracture becomes symptomatic. So now the patient has limited physical activity and we start the nosumab. So it's not like we don't have any toxicity. The impression of all the radiation oncologists working with it is it's still much better than the toxicity of surgery, but the prospective trial is really trying to document if that is indeed the case, that our long-term toxicity is better than surgery. And so far we are quite happy with the local control. Just beware, it's not always so easy to assess local control. RECIST is not going to work, and you have to really think of something else. And what we are doing now is volumetric assessment by recontouring at every follow-up. Yeah, okay. Sorry, that last slide is lost, but it was only the last one, and the content is what I told you. So I would be finished with this case and ready to take your questions.
Thank you very much, Dr. Fossati, for that very interesting case study. We have a few questions, 3 so far. First one, what is LEM?
Yes, this means local effect model, and is one of the two models that are used to calculate the relative biological efficacy. So this was basically a very big part of yesterday's lectures. With carbon ion, we are not then prescribing and delivering and reporting physical absorbed dose as you do with protons and photons, but we are taking into account the different efficacy that has to do with a mix of dense and sparse ionization, which has to do with the geometry of the tumor and the beams. So this is one of the way in which you calculate the RBE, and MKM is the other way in which you calculate the RBE. So the dose that you see on the screen is pretty certain with photons, and also with protons, and with carbon ion, there's a big uncertainty, and you have to find ways to account for that.
Thank you very much. Another question, may you explain again what is a spacer?
A spacer is some material that you ask the surgeon to insert so that you gain space between the region you want to treat and the organs at risk you want to spare. So it is typically done for prostate cancer, inserting a gel between prostate and rectum, and for pelvic cancer, inserting some material that prevents bowel loops and rectum from going close to that. So those are the two most common use of spacer. And of course, it would be the dream of all of those involved in gastrointestinal treatment to have also a spacer for upper abdomen, but so far it's not really so easy to achieve. So it's a piece of inert stuff that you put there to separate the organ at risk from the target. And you don't put it there, you need a surgeon to put it there.
Third question, what material do you choose for the spacer and why?
The idea is that it must not be toxic, it must not produce local irritation, and it must be something that you can shape in different shapes, and must be something approved for surgery, and also should be something that you leave there and you don't have to take out, so you spare one surgical procedure. So there are several options. Initial material was in Japan Gore-Tex sheet. Then they moved to some specific plastic that you can have in different thickness and shape. It's a speg, something it is commercialized but not approved for medical use in Europe. So we had interaction with those firms, and they said, well, we are not really interested. We don't think there is a big market to export that outside of Japan. And then in Italy, where we're using silicone layers, the same silicone you need for example, breast implant, but silicone is very unfriendly to the bowel loop, so those have to be covered with some biological material. And now in Austria, we are using this biological material, so it is derived from the skin of sheep. But eventually the choice is not of the radiation oncologist, but of the surgeon. He is the master of the spacer. And most important is to establish a cooperation with a surgical group, because it's a strange procedure and you have to talk to each other so that it is successful.
Thank you very much. Fourth question, would the planning be better if the ovary was not a concern?
Well, that's a very interesting question. We don't know, but my honest opinion is that the planning would be worse, because by sparing the ovary, we achieved automatically more high LET inside the target, and normally the recomputation in the MKM is not as good as in this case. So this is now an ongoing project that we have here in MedAustron, and is also, by the way, one of the activities that we are carrying out within the HITRIplus projects to investigate how to put more ILT in these big tumors. So the plan would have been easier for sure, but I don't know if it would have been better. Actually, in this case, shows that we implicitly, if you say it, unwillingly did LET optimization in this case, and it should be a sort of interesting concept to explore, to do willingly.
Thank you very much. Fifth question, could your spacer be used in a standard photon-based treatment?
Yes, of course, but spacers are routinely used in photon-based treatment to separate prostate and rectum because they are very easy to insert. It's a outpatient procedure with local anesthesia, or at most spinal anesthesia. It's like a biopsy. But this one is a real surgical procedure. So the question is, do you really need it? And you are not very often so aggressive with normal photons. So if you need it, you can, but we are more afraid of making a hole in the rectum with a very effective carbon beam than you normally are with photons.
And the last question on this list, is there concern with bowel movement intrafraction?
Of course, however, we are really spending a lot of time to have robust plans. So if the point is, we try to avoid going through bowel so that the motion of the bowel is not an issue. But if we are forced to go through bowel, then what we do is a plan that is optimized robustly with different bowel filling. So normally we consider it can be all water or all air, so it is protective. But sometimes this is too much. So of course the concern is there, but we try to I mean, when we do recomputation on control CT, normally we are quite happy. And I think you can manage that simply choosing cleverly your beam angles, and when you are forced to go through, planning robustly for different filling.
Okay. So I see that there aren't any more questions. So Professor Fossati, thank you so much for being with us.
Thank you. Thank you. Ciao, ciao.
Thank you.